revolution with a whole lot of truth. Remedy Revolution is here for you. Ooh. And now here's your host, Aaron Page.
All interviews presented on the Remedy Revolution podcast are designed to provide information and inspiration only. Guests of the podcast may present opinions and anecdotes which are solely their own. And as always, before beginning any treatment protocol, please consult with your preferred medical provider. Hello, everyone, and welcome to the Remedy Revolution podcast. Today's guest, I am really excited to bring to you. You may have seen him on any number of national news outlets, on Tucker Carlson, on the Joe Rogan podcast, and on my personal favorite, the Highwire. He is the most published cardiologist ever, with a great many of those papers that have been published on the topic of COVID-19 and subsequent issues regarding the vaccines, as well as a number of other topics. I am so excited to announce and to welcome you, Dr. Peter McCullough, to the Remedy Revolution. Thank you for being on. Yeah, wonderful. So a couple of questions that really have come up for me, being in this anti-vax world for a very long period of time after working with lots of mothers who have experienced vaccine injury with their own children. I have to ask, what was the linchpin that really started you questioning, particularly I know first was the COVID-19 vaccines, and start kind of going down that rabbit hole even further?
Mm-hmm. Well, I'll just make a response to some of the terms. So, I don't think anybody is anti-vax. We're not anti diabetic medicines or anti-heart medicines or anything else. We are risk aware. So it's a difference. So we're vaccine risk aware. So I don't actually use the word anti-vax. I say, listen, I'm just aware of the risks, of which many people have not been made aware over time. We just accepted vaccines as routine without any risks until we actually see the consequences. And the other thing is a rabbit hole. Rabbit hole is like a diversion or what have you. No, this is mainstream. This isn't a rabbit hole. This is kind of our main issue that's facing America today. And it's certainly the main issue that faces a child that's well. A child that's well largely has no interventions done to them except for mass vaccination of a very accelerating, intensified vaccine schedule. So I think what brought it to the front of my consciousness was the COVID-19 vaccine safety debacle. And I think almost everybody watching this understands it has been a debacle of epic proportions. I just finished a whole day in clinic, and I saw patients with blood clots and strokes and heart damage and heart failure, all as a result of the vaccine. And I'm dutifully entering all of these on the Vaccine Adverse Event Reporting website and trying to get the vaccine card. It has just been it's been an overwhelming 3 years of really what is a debacle. And many of you know that I've called for removal of all COVID-19's vaccines from the market in 2022 in U.S. Senate, now in 2023 in the U.S. House of Representatives, the European Society of the European Parliament, which advises the European Commission, and then the Association of American Physicians and Surgeons 2023, a leading medical group, kind of the top doctors in the United States, American graduates largely, has called for removal of all the vaccines from the market, and the World Council for Health. So with all that momentum to pull the vaccines from the market, it brought up the issue. And I think for me, it was approval of the COVID-19 vaccines as emergency use authorized products for 6-month-old children, 6 months and up. And that panel that decided that, the ACIP panel, how I factor this in is that, listen, if they waved this on and they thought this was a good idea, have they had similar lapses of judgment with other vaccines? And then I started to review them one by one.
Yeah, absolutely. And I think, just as a spokesperson for that, the autism community, I'm very grateful for that because, so often many of these parents have been gaslit for, decades, really. And it's very unfortunate and very sad. So a couple of things. I have seen a couple of things in my own clinical experience that I'm curious about. and I'd love to know your thoughts on those. So I'm noticing I deal with a lot of children who have PANS PANDAS diagnoses, which is a neuroimmune disorder for those of you who are not familiar. I'm seeing a large rise in PANS and PANDAS type symptoms, sometimes misdiagnosed as mental health, anxiety, OCD, those kinds of things. But then looking at their labs, they have very high titers for COVID, whether or not they've been vaccinated. Is that something that you are seeing in some of your research as well? This rise in what perhaps misclassified as mental health disorders and could actually be more of a neuroimmune response?
I have not seen a PANDA patient myself. So this is an immune problem is thought to be due to cytokine signaling after an infection, typically an ear, nose, and throat infection, and then the development of some neuropsychiatric symptoms. With PANDA, one of the characteristic features of the syndrome is actually hallucinations, which doesn't happen in too many others. But I am aware, in fact, a relative of my co-author of my book, John Leake, his brother's kids developed a PANDA-like syndrome. And I know Dr. Pierre Corey, his kids as well. And this can be post-streptococcal, post-viral. And I agree with you. It seems like it's more common. Maybe it's recognition. But the spike protein that is largely in all of our bodies now from the infection or from the vaccine, and we have antibodies to the spike protein, that seems to be playing a role in immune signaling or immune dysregulation in some respects. And the terms immune imprinting has been used, immune debt. So there's like a debt that's paid. But the characteristic features are proclivity to other infections. So we've already seen an outbreak of adenovirus hepatitis in children, including some kids who died or needed transplant. That occurred during the pandemic. Episodes of streptococcal infections. We've heard about leprosy, for instance. I haven't heard about leprosy in a long time. And so all of these may be because the immune system is impacted now by the ubiquity of the spike protein.
Yeah, it's very interesting, and I think a conversation that really could use some more investigation for sure. So another thing that came up for me is this. I've had a couple of patients who've come to see me who have been vaccinated and who do not show any antibodies at all. What would you suspect that might be?
That's quite interesting. In the report by Schmeling and colleagues from Denmark, it was about 30% of people who took the vaccine didn't even have a sore arm. Nothing, no effect whatsoever. And the institute that was supposed to assess investigate the vials in terms of quality and purity, decided that a third of the vials didn't need any type of inspection. This has all been summarized on my Substack. We're concerned that actually some of the vials may have almost nothing in it. Mm-hmm. And if that's the case, then there wouldn't be any antibody response. To me, that's the most readily available explanation. There are people who take the shots and just nothing happens. Now they get COVID because the vaccines don't work, but they don't have any side effects. And maybe it's those individuals with no side effects have little or no antibodies. Now, that is the type of investigation we need.
Mm-hmm. Absolutely. Absolutely. So as I mentioned, in my world, we do a lot of the conventional wisdom for a PANS PANDAS patient or those with neuroimmune disorders is to give IVIG treatment. However, I have grave concerns over the quality of the blood product now coming out in the United States. What about that? And should we be concerned?
Well, intravenous immunoglobulin is just a temporizing measure anyway. And what it is you're giving a broad pooled blood product of antibodies to try to interfere with some type of antibodies that one either knows or doesn't know about. So I know the Japanese are reporting this. They're using it fairly extensively for myocarditis and other conditions. But, I personally don't use it in clinical practice. It is a pooled blood product. I guess there's always risks with that. People have expressed concerns that the blood supply isn't clean, that maybe, in fact, there is spikes of protein in the blood supply or even messenger RNA or adenoviral DNA. That's never been proven. because the blood supply has never been tested for spike protein. And there are ways to test for it, whether it be an ELISA antibody-based assay or even by mass spectroscopy. A paper by Brogna and colleagues caught my attention from Germany. People who took Pfizer or Moderna, Brogna measured freely circulating spike protein, vaccine spike protein, because Pfizer and Moderna use the same signature on it. So you can tell if it's a spike protein from the vaccine. Freely circulating spike protein from the vaccine for 6 months after the shots in half of people. Half of people, it wasn't detectable. So again, these are some of the mysteries. But you can imagine people walking around with spike protein in their bloodstream. Now, that's not healthy. The spike protein is known to damage the heart, the brain, cause blood clots. It cannot be healthy to be walking around with circulating Wuhan spike protein. This protein that was engineered in a Chinese biosecurity lab in people's bloodstreams. I mean, it's a terrible thought. So if it's in the bloodstream, it probably is in oral and nasal secretions and sweat and etc. It's such an unsettling idea. And the academic community, the mainstream orthodoxy, has not reacted to the Brogna paper at all. And it's not just Brogna. There's been papers from Swank and Ogata from Harvard. They've also been ignored. They've also measured spike protein in the blood of the vaccinated.
So having been in the medical publishing world, I have to ask, what is it? I'm sure you've written papers, but I'm sure you've been on the other side of that and being in the peer review segment of that population as well. So what goes through these people's minds, do you think, these doctors that are reading through these papers, that the ones that, particularly like with the hydroxychloroquine paper that was, unfortunately, they were giving very high doses to people who had already been ill for a long period of time and had negative effects with that particular paper. But what is it, do you think, that goes through these doctors' minds when they review and approve of these papers? Because it can't be just complete blind ignorance, right? There has to be some kind of recognition of, well, that's kind of a strange marker. I wonder why they did that.
Mm-hmm. Let's take the example of the vaccines. I think that's more front and center.
Sure.
I'm a former professor of medicine. I've been in big academic medical centers my entire life. And I can tell you, when we have a manuscript and it's all assembled and reviewed, it typically has to be reviewed by a department chair. That would be me, or a director of the research institute. And I can tell you that an institution that mandated the vaccines, promoted the vaccines, encouraged or forced the vaccines on their faculty, their students, residents and fellows, forced them on patients, that institution is not going to approve a manuscript that concludes the vaccines are dangerous. They're simply not going to do it. They're part of this narrative. So you can imagine how many manuscripts are out there that never got out the door describing horrific complications because of institutional bias. Now, if a paper is put together and it does get out the door and gets submitted to a journal, I've had an experience, and I'm one of the most published people in COVID-19, so I can speak to this, where the manuscript goes into the editor of a journal, and the editor then, distributes it to an associate editor. I've had a situation where all the associate editors refuse to handle the paper. So none of them want to touch the paper because it's describing some horrible complication of the vaccines. And so it's dead on arrival. We've had, manuscript after manuscript just rejected with no review. We've had manuscripts then get inordinate amounts of review. And I was a former editor of two journals. And, typically we'd have two reviewers and an editorial decision. That's it. Yeah, but I've had papers, even during the early treatment days of COVID-19, where there were 6 reviewers assigned. 6 instead of 2. And then, so the number of comments that have to be handled is tripled. Recently, first author paper by Mead, I'm the senior author, had, I think the total number of reviewers was 12, and the total number of comments was over 200. The number of references basically reached nearly 300. This is unprecedented. What I'm telling you is that every effort was made to try to reject this paper. So what I think is going on is institutional bias, because they promoted the vaccines. In the United States, they probably took countermeasure money, so they must feel financially obligated to promote the vaccines. But at the editorial level and review level, what I think is going on is I think most of these people took the shots. I think most of the doctors took the shots, and they can't psychologically handle these manuscripts describing these horrific complications, which could happen to them or their family members. I think they are absolutely psychologically paralyzed. And I know this among my colleagues, my friends in academic medicine, they can't even talk about this. They can't even pick up the phone and have a conversation. They're just absolutely positively paralyzed that they're seeing this play out in their patients, and they wonder if they're going to be next.
But is there a tipping point where the ethical responsibility overshadows this kind of personal shame or whatever it is that's holding them back, do you think?
No, I think it comes decades later. It really does, decades later. And many times after people retire. And the working example of this is smoking. Mm-hmm. There was a European doctor in 1912 that said, listen, we think smoking is causing lung cancer. Doctors like, no, it can't cause lung cancer. And then in 1950, Sir Austin Bradford Hill published the tenets of causality. He walked through it and said, listen, this is compelling. Smoking is causing lung cancer. Doctors and nurses continued to smoke. Doctors and nurses continued to be, actors for smoking advertisements, tobacco advertisements. They smoked through decades, denying the obvious fact that you're breathing in a carcinogen is causing lung cancer. And even in The Emperor of All Maladies, which is a great Pulitzer Prize winning book by Mukherjee, Dana-Farber Cancer Fellow at the time, he describes the lead surgeon from Johns Hopkins, taking out lung cancers, and he was smoking as he takes out the cancers, telling the students and fellows, no, smoking doesn't cause lung cancer. He himself dies in denial of lung cancer. So I can tell you, these doctors have taken the vaccine. They've continued to take the vaccine. They are publishing biased papers. The only papers that get into literature are papers that say the vaccines are safe and effective, even though they're not. And so now this bias is so strong that, and I've even seen doctors where, they don't actually begin to question this until they themselves get a blood clot or myocarditis. And each shot is like a shot of Russian roulette, where people, do fine with the first 3 or 4 shots, get myocarditis on the 5th shot. Recently, the Mayo Clinic came out, the Mayo Clinic Vaccine Safety Center came out in a very brief paper, no analysis, and said the vaccines have an overwhelmingly positive safety profile. Especially when there's no analysis, it's just an opinion, or we'll see papers like this where they're describing fatal myocarditis. So some young man takes the vaccine and is going to die, and does die. And the authors start out by saying vaccination is safe and effective, but now we're going to describe this fatal case. So I think it's very much psychological, and it's in the minds of doctors. Today, I saw patient after patient where the doctors, the patient took the vaccine, the doctors handled the blood clot, they handled the heart damage, but they never told the patient it was related to the vaccine. They never asked about the vaccine, and they never reported it to the CDC. So today, that's all I was doing, is putting it all together, documenting it, take care of patients, and reporting to the CDC. So can you imagine? The CDC VAERS systems is overwhelmed with adverse safety data on COVID-19 vaccines. It has to be a tiny fraction of what's going on, because only diligent people like me are actually reporting cases to the VAERS system.
Right. I just feel like there are so many that are affected, and we're not even making all the connections yet. You mentioned myocarditis, which obviously has been a huge focus of your work being a cardiologist. But, we're seeing so many other adverse events and this whole died suddenly phenomenon, and, the excess mortality across the board. So what kinds of things specifically are you able to mention that you're seeing maybe in clinical practice? Obviously, it's going to be skewed more towards cardiac events, but perhaps things that maybe your colleagues are seeing as well.
Well, let's take the all-cause mortality data. And what I try to do is I just stay within the peer-reviewed literature. And when you see me testify in the Senate or the House, or you see me on national TV, I'm the only doctor, the only public figure that cites the data. I'm the only one. Everyone else just kind of generally comments, but I cite the data. So when it comes to all-cause mortality, there was a social science paper that used survey techniques, but large sample size. The first author is Mark Skidmore of Michigan State. It was published in the journal Medicine, Public Health Policy and the Law. And there, the mean age of someone dying that people think die of the vaccine is 48 years old. It's 48. And then a paper that I'm the senior author on, Nick Hulscher is the first author, published in the Journal of the European Society of Cardiology, very important paper, describes fatal COVID-19 vaccine-induced myocarditis, proven by autopsy. And what we know there is that patients take the vaccine, and that when these deaths occur, they don't even have a chance to get an MRI or get a diagnosis ante-mortem. They're simply dying precipitously a few days after the shots. And at autopsy, they have fatal myocarditis. We reviewed all the autopsies, and it's clear. Now, occasionally there'll be the heart and other organs involved, but primarily it's the heart. We now know that the FDA put out warnings that the vaccines cause myocarditis in June of 2021. The FDA knew about it in May of 2020, but they put out the warnings. I mean, everyone should know that the vaccines cause heart damage. People just continue to take the shots like, well, it's not going to happen to me. Now, two studies, one by Mansugian, the other one by Buren, putting the data together on shots 2 and 3, just assessed before and after, but it's comprehensive assessment of troponin and other studies. The answer is 2.5% of people get myocarditis. But more broadly, a paper by Nakahara and colleagues show that everyone who takes the shot has some cardiac involvement because the cardiac PET scans turn abnormal. They begin to shift from free fatty acids to glucose as preference, almost as if there were micro blood clots in the capillaries of the heart, changing this kind of ischemic pattern that we see on PET scanning. But it's really striking. Everyone who took the shot, the cardiac PETs change. Now, the unvaccinated, the cardiac PETs are fine. And this lasted for about 6 months, as far as they've looked. So we are seeing cardiac arrests where there's no ante-mortem myocarditis, and there's really not much seen on autopsy. And we think it is this kind of metabolic, inflammatory cardiomyopathy that develops in the vaccinated. The heart rate's usually elevated, in most cases that I've reviewed. But in the Hulscher paper, we make it very clear that the next person who dies with no antecedent disease, no history that we would think could lead to a sudden death, and they suddenly die, and they're vaccinated, it is the vaccine until proven otherwise. We should conclude it's the vaccine. We've seen cases now 2 years after the shots, and we attribute them to the vaccine. I recently testified in the U.S. House of Representatives, and they asked me, Dr. McCullough, well, how long is this going to go on? I said, according to the FDA regulations, Pfizer, Moderna, Janssen, and AstraZeneca are gene transfer technology platforms. The regulatory window of concern is 5 years. That's arbitrary, but it's at least 5 years. So that's what we're looking at. Anybody who dies now who's vaccinated, there's no other explanation based on our peer-reviewed publication in one of the best cardiology journals. By the way, it's the most downloaded and read paper they've had in 2 years. It is the vaccine. And this is a terrifying revelation. Even I think it was yesterday, the Australian Senate again turned down an all-cause mortality inquiry. But at least the Australians have tried to bring it for a Senate vote. In the United States, there's no official inquiry about why so many people are dying.
So looking forward, what do we do? Those who have been vaccinated, I know you have protocols that you have implemented to assist them. But from my understanding, this is not something that we can detox out of the body. And number one, why is that? And number two, what can people do to increase their health at this point?
Let's take the genetic material first. Most people who took a shot in the United States took Pfizer and Moderna. So we could restrict our comments to messenger RNA. But 94% of vaccinated patients took Pfizer and Moderna. Overall, about 75% of Americans took a shot, 25% didn't. The CDC disagrees, by the way. The CDC thinks it's 95% of Americans took a shot. That's on their website. But I think the COVID Community State Survey is more accurate. And they do imply in that report that the CDC is overcounting because they're not keeping track of vaccine cards. And that fits with my practice. It can't be 95% vaccinated. I just see too many people in public life, in large numbers, who are not vaccinated. I didn't take the vaccine. It was never safe enough for me. My wife didn't take it. What we know is that the messenger RNA has been intentionally modified through a process called pseudouridination. In addition, the caps of the messenger RNA are synthetic nucleoside analog caps. Essentially, Pfizer and Moderna made this messenger RNA indestructible. And there are no known human enzymes that can break it down. No study has ever shown the messenger RNA is broken down and cleared from the body. In fact, these were pushed on the market without knowing the fate of the messenger RNA. This is an astounding revelation. And to make it even more fantastic, Carrico and Weissman won the Nobel Prize for this pseudouridination step. And people have asked them, well, what have you created here? Can this ever get out of the human body? And they have no answers. Now, Carlson and colleagues from Harvard has shown the messenger RNA stuck in the human heart. So for sure, it's in the heart. Castriota has found it in the bloodstream at least 30 days later. We just don't know how long the messenger RNA lasts. A paper by Zhang and colleagues from China showed that a restricted length of the messenger RNA, coding for the spike protein, but just the receptor binding domain, that could actually be loaded into an exosome and be absorbed through the GI tract in milk. They were actually able to feed the milk to mammals and get it to be absorbed after 3 feedings. So this messenger RNA is certainly in the bloodstream, it's in tissues, and it's on the move. And until we know otherwise, I mean, one assumption is we can't get it out of the body. Now, what is it doing? It's producing spike protein. The spike protein was intentionally engineered in a Chinese biosecurity lab in Wuhan, China. The engineering of that spike protein was devised by Dr. Ralph Barrick at the University of North Carolina, Chapel Hill. Vineet Menachery was the first author, and they memorialized this in 2 papers in Nature Medicine and Proceedings of the National Academy of Sciences, where they said, we did it. We created a chimeric virus, the nucleocapsid, and then this modified spike protein, and it can invade human respiratory epithelial cells. So it was created in 2015, 2016. That's the spike protein, and that's the genetic code for the spike protein. Barrick had a material transfer agreement in place with Moderna before the pandemic, presumably for the genetic code of the spike protein. So Pfizer and Moderna make this spike protein. It's produced for an uncontrolled duration and an uncontrolled quantity in the human body. I've told you that Brogna has been able to measure it in blood for 6 months. So it looks like the messenger RNA is cranking this for 6 months. And then injections every 6 months, we assume there's more and more spike protein. Mm-hmm. We don't have an immediate assay to measure spike protein. Estimates by former NIH researcher David Scheim estimate that 40% of it is attached to red blood cells. Some is within white blood cells, and the rest is free in plasma. It's obviously in tissues. So the body must have a lot of it. Okay? Mm-hmm. It is everywhere. That soon the Invitrogen, that's the company that makes the assay, will have a spike protein assay for blood. And I bet once we have that, that'll be the most widely used blood test ever. So the proposal is to at least catch up on the spike protein. Mm-hmm. And so to do that, again, the human body doesn't have a way of breaking down spike protein. It looks like the spike protein from the virus, when it interacts with the ACE2 receptor as it's invading the body, it sacrifices the S2 segment. Because people have had the infection, you can't find the S2 segment. You only can find the S1, the outer segment, typically within monocytes. So the body is trying to handle this within its immune system. But in the vaccinated, you find full-length S1 and S2 segments. There's only 2 segments, and the Pfizer, Moderna, proline signature. And so the proposal is to use external enzymes to help break down the spike protein. So the Japanese have shown nattokinase, which is a natural enzyme derived from the fermentation of soy, that nattokinase in the form of a capsule supplement can break down spike protein in intact cell and cell lysate models. And then additionally, bromelain, which is a family of enzymes derived from the stems of pineapple, again, available as a supplement, a capsule supplement, that also breaks down spike protein. Interestingly, both are forms of blood thinners. Nattokinase prolongs the D-dimer number and it is a thrombolytic, an endogenous thrombolytic. And then bromelain is an anticoagulant. It prolongs the prothrombin time. So both are forms of blood thinners. And the third one that's in the McCullough protocol is curcumin. This is a naturally available product from turmeric, and it's anti-inflammatory. That's actually even gotten to randomized trials. It's anti-SARS-CoV-2. It's anti-inflammatory for the spike protein, reduces inflammatory factors. So all three of those have enough evidence to put into a protocol. It's called McCullough protocol, base spike protein detoxification. We have 2 peer-reviewed publications on this. It's very solid. Go to my website, petermcculloughmd.com. That'll kind of show you the graphic, although you can go to the original. Publications now listed in the National Library of Medicine. The doses are nattokinase, 2,000 units twice a day, bromelain, 500 milligrams twice a day. Those must be taken on an empty stomach. And then curcumin, 500 milligrams twice a day. We typically combine curcumin with bioperine or piperine to aid in absorption considerably. So typically 5 or 10 milligrams of piperine. Now, these are starting doses. We can actually markedly increase the doses if they're well tolerated. And although we don't have large randomized trials, I can't make any therapeutic claims. Under direct observation in my office and with all the doctors and nurse practitioners here, we are observing patients slowly get better. It typically takes even out to a year. I've held some calls with the doctors in the UK that's been doing it. There's the same observation. People get better. People say, well, what do you mean by getting better? The neurologic symptoms clearly get better. Brain fog, headaches, ear ringing, numbness and tingling. I think the neurologic symptoms are most responsive, tremulousness. And we've seen the cardiovascular condition improve, but we're always using other drugs too. So it's really difficult to tell. We're seeing parameters like the extended range antibody against the spike protein go down, inferring that we are clearing spike protein from the system. So McCullough protocol based spike protein detoxification, that's now in a sense become the worldwide standard. Previously, the World Council for Health and the Frontline Critical Care Consortium, they had lists of things to try, but it was very disorganized and it didn't have any approach for the spike protein. Some people say, well, take ivermectin or take N-acetylcysteine. Well, that's fine, but it doesn't get rid of the spike protein. We got to get rid of the spike protein, and then you can add other things to it. So I'm not against any of those things. I'm just saying do the base and then add to it. And that's the reason why we put base in the name, and that's been fully copyrighted now. And so I think that'll stick.
Yeah. So what about for people like myself who did not take the vaccine? However, I've had infectious forms of COVID now 4 times. I've been very symptomatic every time, to the point where I needed IV fluids and things like that. None of the respiratory symptoms, however, for me, it was always body aches, high fevers, chills, and, symptoms like that, extreme, crushing fatigue. So what is going on with people like myself who continuously get reinfected and, despite taking tons of preventative measures as well on top of that? The last time I had COVID, for example, I was on a 90-day protocol of ivermectin. So, so many of these infections seem to be penetrating even though, we're doing those things that we need to be doing for prevention. What do you think that's about?
Sadly, mass vaccination is really worse than the pandemic. So the virus keeps mutating and then reinfecting people. So unfortunately, you're receiving the back end of this mass vaccination. So the virus keeps jumping from person to person. I'm like you. I've had it 3 times. This last time was really bad. My ears are ringing now. I can't breathe the same. There's no doubt about it. People see me on TV. I had it twice before 2022. 2022, I had 12 colds. 12. Never have that. I don't drink alcohol. I run. I'm fit. I watch my diet. It's like 12 colds. Then in 2023, 6 colds. The last one I think was COVID. And oh my Lord. I like you. I needed an IV. Couldn't breathe. It was bad. Now my ears are ringing, characteristic post-COVID syndrome. So what we know there is, I can tell you, my blood type is A positive. I wonder what yours is. But
I'm a B negative, I believe.
Okay, but we're up on the Kell antigen scale. O negative is the best. So what happens is most of the symptoms that you and I have, it's because our red blood cells are being stuck together by the spike protein. It's called hemagglutination. This paper by David Scheim, which I've reviewed on my Substack, he's a former NIH scientist. It has over 300 references, has all the figures. It's pretty clear the spike protein from the infection and from the vaccine is causing these symptoms. So again, base spike protein detoxification, it actually may work better in just the post-COVID patients now, no doubt about it. Other strategies are to stop this pattern of reinfection. So commonly, I recommend to patients things to actually help modify the microbiome. Because if the nose and mouth can fight this off, you're probably breathing in the virus every day, honestly. You're probably coming in contact with it every day. And the spike protein for sure. So I recommend xylitol-based products. Xylitol is real interesting. So one brand name is Clear, Xlear. And so the spray is Clear, and then the gargle is called Spry. That's what I use. And what it does is it's a natural sugar. It doesn't get absorbed to the body, but it shifts the bacteria towards the favorable bacteria in the nose and mouth. And what's been described to me is there's about 800 good guys, about 11 bad guys that weaken us, and you're strengthening the good guys, and that can help fight off the virus. There's been prospective randomized controlled trial using a xylitol nasal spray every day actually reduces your chances of getting it again. I mean, that's pretty solid. Now, people get acutely ill, we switch over to iodine-based products. But, chronically, I think the xylitol is very safe. It reduces rates of sinusitis, reduces rates of dental cavities. I mean, it really is amazing. I just brushed my teeth with the xylitol toothpaste. I really do think that's the way to go. Another good way to strengthen a microbiome is Activia yogurt. Activia yogurt, experts tell me, is actually even better than taking probiotic colonies. Just a simple, so it comes in a small container. It tastes pretty good, actually. It's pretty easy to eat Activia. Do that. Another piece of advice is eating sugar and starch. In every single study shows it worsens this. It facilitates infection, reinfection, long COVID syndrome. The literature is just loaded with this. And, I was eating desserts and chocolate and this, and I've stopped all of that now. I just can't. I can't keep feeding this. And we've got to stop this cycle of reinfection because I think it's affecting all of us right now. You and I sounds like we're in the same camp. I wonder how many of your listeners are in the same camp. Didn't take the vaccine, but had COVID multiple times, now are kind of in our boat.
Yeah, absolutely. I do wonder the same because, people have postulated about the idea of shedding, but, I don't know that I necessarily believe that that's what it is, but I do believe that there's certain amounts of us who perhaps there's a predisposition. Maybe it's, we know, like, for example, low vitamin D levels predisposes you to COVID as an example. But, I do have to wonder if there's something else out there. I don't know. Maybe that's a future study.
Yeah, but you can think about this. There was a test that's still available if you actually want to assess as another test for immunity besides the antibodies. It's called the T-Detect test. I had this done actually, where you can actually see if your T cells have previously reacted to SARS-CoV-2. And the way they test for it is they actually look for chromosomal rearrangements for various proteins that are self-surface receptors on white blood cells. So listen, when you get SARS-CoV-2, it's in your body, it's in your cells. Your cells are making genetic changes to try to respond to it. There have been studies, an autopsy study to quote from the NIH is by Chertow and colleagues. Do you know people who got COVID and even died, 3, 6, 9 months later, they found the virus was alive and replicating in the body. It was in the skin, the eyes, the lungs, all the tissues. There's been a gastroenterology study done in children where they get endoscopies and they get biopsies and fluid from the jejunum, the small intestine, and the virus is alive 5 months later. So, this virus we're still learning more about, but it's not like you have it and in 3 days you don't. One can test positive intermittently for 6 months or more. And all the studies suggest it lasts a lot longer than what we thought.
Yeah. And interestingly too, for myself, as well as, many of my patients and colleagues, we've noticed an increase in reactivation of things like Epstein-Barr or other herpes viruses or, streptococcal infection, and certainly staph infection was rampant when we were masking in particular. But, now we're looking at this kind of reactivation of all these other pathogens. And I know that certainly must play a role. Is that something that you're seeing as well?
Definitely. Now, The infections to look for reactivation, let's kind of go through them. First is varicella zoster. So that would be whether you had the natural chickenpox infection or the vaccine, you're still getting the virus. I want people to understand this. You get chickenpox vaccine, you're getting set up for shingles later on. Actually, the studies show actually much higher risk of shingles than with the natural chickenpox infection. But either way, the varicella zoster virus gets installed in human DNA. You never get rid of it. So people end up with shingles later on. And we see reactivation shingles after the vaccine, after COVID all the time. I had a young woman who was a pharmaceutical representative, and she developed actually invasive rectal shingles after taking the vaccine. Dianne Feinstein, who is a deceased U.S. senator, purportedly took the vaccine multiple times, and she developed neuroinvasive varicella zoster, just invaded her brain and killed her. Justin Bieber has another varicella zoster infection called a reactivation called Ramsay-Hunt, and then clearly Bell's palsy. Right. Those are the common ones. Now, other viruses that can do it, certainly herpes simplex 1 and 2, so recurrent mouth ulcers, and then genital ulcers, that's been well described. Cytomegalovirus, that can kind of make people chronically ill, that's another. And then a big ticket item is Epstein-Barr virus. Epstein-Barr is known as the mononucleosis virus. 90% of us are carrying it in us. And so when we check the panel, by the way, it's always going to be positive. There's always antibodies for Epstein-Barr. What you want to look for is the early antigen panel. And in fact, you can even measure the PCR of the virus in the bloodstream. But the bottom line is we're seeing a lot of Epstein-Barr virus reactivation.
Mm-hmm. Yeah, absolutely. And I know that's been true for me, particularly the last couple of times that I've had COVID. Then I've gone in, I did have active mono as a young teenager. And so, I knew that that was a risk factor for me. And sure enough, as soon as I had COVID, then I started getting all these other ailments and what felt like Epstein-Barr again, or active mono.
But did you have the early antigen positive on your panel?
The first time, I believe I did. The second time it was not. But
yeah. See, if you have the early antigen positive, and if there's submandibular adenopathy, pharyngitis, or mouth ulcers, you have a really good case for reactivation. Now, severe reactivation, where the lymph nodes are just enormous, we actually have to use prednisone for that. Otherwise, the most common approach is to use acyclovir or valacyclovir, which has some off-target effects on Epstein-Barr, and we combine that with dipyridamole. It's actually an antiplatelet drug that has some EBV qualities. But so far, that's all we can do. Hopefully your body will fight it off with your natural immunity. But we should talk a little bit about immune boosters. Do you take anything to boost your immune system?
Oh, gosh, lots. Let's see. I've taken a number of things, vitamin D, I've taken quercetin, bromelain. Those are specific to help with histamine response. I've taken, what else? I'm drawing a blank here, but lots and lots of things.
Let's talk about that. So you mentioned vitamin D. So vitamin D, clearly, the data are very clear on this. And if anything I've learned, McCullough protocol for acute treatment, early on, we upgraded it actually up to 20,000 a day of vitamin D, just the over-the-counter vitamin D3 for acute treatment. And knowing what I know now, I'm upgrading most people chronically to 10,000 units a day, including myself. So that plays a role. Quercetin, a polyphenol supplement, that actually has some evidence base to it for sure. I think zinc, 50 milligrams a day when you're acutely ill. Right. Otherwise, zinc every day, I don't think plays a role. It tends to interfere with copper metabolism. So I don't take zinc every day. Vitamin C, again, I think when you're sick, and it's typically high dose, like 3,000 units every 6 hours, 3,000 milligrams, but I'm not sure every day if you have a good diet that plays a role. People have been very interested in elderberry extract and echinacea. And I can tell you my go-to immune support for lack of any other description is actually a microgel. It's called Immune Super Boost by the company Healthy Cell. So it's healthycellaltogether.com. immune super boost. And you can actually, I take it twice a day and you get relatively instantaneous absorption. I don't know if it's working or not. All I have to tell you is that when I'm on it, I just don't seem to get COVID. And when I'm off it, I mentioned that to my wife. I said, I just ran out. I said, I've got to get some more. I don't know if it's a good luck charm or not, but there may be some relationship to exogenous supplementation and the proclivity to these infections. We've already covered, the xylitol-based products, diet, fitness. Tonight, I'm on TV almost the entire day today, but tonight, before I go home, even if it's dark, I'm going to go run and do push-ups and sit-ups. I have to get some exercise. I think that's really important.
Yeah, absolutely. I find, I always say the exercise is great for my physical health, but also it's a mental health thing. I have to move. I'm just kind of one of those people. Absolutely. Okay. So I want to just touch on this because it's something that we've talked about with Dr. Mark McDonald on the podcast, but you made a presentation just recently at the Autism Health Summit speaking about, I know we're completely shifting gears here, but but speaking about the prevalence of this idea of changing genders, specifically in the autism population, and this being a very high percentage of these young children who are identifying as perhaps the opposite gender. So you presented a lot of research there, and I just kind of wanted to give our listeners a little bit of a purview of some of that research. If you would be so kind as to give some of that information here.
Yeah, it is a late-breaking development, quite honestly. Let's just set the stage. We're at about 800 papers right now on the immune system and autism, and about 200 in particular about immune system dysregulation and what I call hypervaccination in autism. Autism, when I was a child, was 1 in 10,000. Now it's 1 in 36. It's an absolute epidemic that's exploding, and it's directly correlated with the number and intensity of vaccinations. It may not be any single vaccine or any single additive like aluminum or thiomersal, or it actually probably is the neuromodulation, just like you talked about PANDA as a neuro immune syndrome. That's probably the case. And can we prove it? No. But is there any other explanation? No. I mean, the risk factors for autism are older parents and siblings with autism. That's it. And then the vaccines. If you ask the converse, are studies where children receive no vaccines, are there lower rates of autism? And the answer is yes, way lower. There's an Amish study, a paper by Paul Thomas, another one by Hooker, Miller, Mawson. These are convincing. The children who are unvaccinated from birth, I mean, they're fortunate to have their parents see this. They're in great shape. Now, autism is part of a grouping of disorders. The Europeans call it the essence disorders, and it includes autism spectrum disorder, Asperger's disease, attention deficit disorder. There's some motor disorders and even seizures called essence disorders. And what was noticed was that if a child, and there's a European study to support this, takes a battery of vaccines, and then they have a reactogenic episode where they get sick and have a febrile seizure, there's about a 40% chance they'll go on to have one of these essence disorders. I mean, that's huge. So when the parents say, listen, my child was fine, I came in for this well baby check, got a round of vaccines. We're talking 3, 6, 9, 12 plus vaccines all at once. And then they got sick and had a seizure, and then they weren't the same again. These vignettes now are very well solidified in the medical literature. And the doctors really need to listen to this because that is the genesis of these disorders. But, that the Europeans were ahead of America on this transgender crisis, this new sudden crisis where children have ambiguity regarding their gender. They have dysphoria. They're uncomfortable approaching puberty. And in a paper by Vander Meesen and colleagues from the Netherlands, and this is about 15 years ago, was reporting that about 20% of the children who came forward for gender change had autism. They had clinical autism. Can you imagine how many had autism spectrum disorder? Then a paper was published by Warrior and colleagues, huge study, that looked at LGBT people and then assessed him for autistic traits using standardized psychometric techniques. And guess what? They scored off the Richter scale for autism.
Right.
Okay, now this transgender crisis goes into full gear, and the Autism Advocacy Network is one of the strongest proponents for transgenderism. And so they're actually fighting for transgender rights, trying to stay these bans on transgender surgery. And we've learned so much about this. You know, the transgender crisis, in a sense, came out of nowhere. When I was a kid, the rate of LGBT was way less than 1%. Now the estimates are a high school senior today, about 20% of people in a class will actually try to change their gender. They'll try to go from man to woman. And, you know, it's a board exam question for family medicine and all the relative specialties that if a child comes forward with gender ambiguity or dysphoria, the first thing the doctor should do is start puberty blockers. That's actually the correct answer on a test to show you how far this has gone. And there are data that clearly autistic children and young adults, they feel ostracized, they have low self-efficacy, they're suggestible. And so if they approach a counselor regarding an interaction with the opposite sex or dating or what have you, they could easily be, you know, convinced to attempt to change their gender and then live out this fantasy of appearing like one is part of an opposite gender. But, you know, people are either born a boy or a girl. That's, you know, that's set from the very beginning of life. You know, mothers get ultrasounds to figure out what sex it is. So it's clear when the baby comes out of the womb, it's either a boy or a girl. And so, so people are born in the correct bodies. But if they develop this psychological fantasy of trying to change into the opposite gender, what I presented to the audience was just an absolute disaster. So there are papers, there's one in sexual medicine showing that doing this transgender medicine increases the burden of psychiatric disease. It doesn't make the psychiatric problem go away. It increases the burden. The hormones make the kids sick. 60% of the kids, nausea, vomiting, headache, weight gain, acne, can't sleep. I mean, it's awful to take hormones when the normal human body is not expecting to get these hormones. The surgeries are catastrophic. The mastectomies in the girls distort the lymphatic drainage, and there's drainage problems, cause contractures of the chest. Breast implants in the boys, that's probably the most benign of all the surgeries, but still it's disfiguring. And then the bottom surgery, you know, all the academic medical centers call it tops and bottoms. The bottom surgery for the boys is a penile inversion vaginoplasty. So the penis is open long ways, it's cored out, and then it's stuffed back in the pelvis as a rudimentary vagina. It doesn't drain correctly, doesn't handle bacteria well, it gets infected. And it's obviously disfiguring, it's permanent. Sometimes the testicles are removed, orchiectomy, you can't get that back. And then for the girls, what's done is a clitoris enlargement procedure called a metoidioplasty. It doesn't work very well. The clitoris is about as big around as a hot cocktail weenie. It doesn't really function as a penis. Or a more destructive procedure called a phalloplasty, where a large chunk of skin is taken out of the arm and subcutaneous tissue or the thigh, and it's made into like a hot dog-like vestigial penis, and then it's oversewn on top of the clitoris. It doesn't really function as a sexual organ, doesn't drain urine correctly, and then the arm or the thigh is disfigured. So what caught my eye was a paper by Jackson and colleagues from the UK published in JAMA showing that children and people who take this transgender journey, that they have higher rates of homicide, suicide, and death from other causes.
Right.
So to summarize, transgender medicine in the youth increases the burden of psychiatric care, has surgeries that are complicated with infections and problems and are sterilizing and disfiguring, and the entire package leads to increased mortality. So transgender medicine in the youth is actually bad medicine. And doctors and nurses and administrators, they should have never done this. They should have policed themselves, but sadly they haven't. And all the big marquee academic medical centers are doing this. The societies are saying this is standard of care. And this is so disturbing that actually states have had to ban this, like the state of Texas. They've banned transgender medicine for the youth. Now, it's completely different as an adult. If an adult wants to live out the fantasy, looking like the opposite gender, they can do so, in my view, if they pay for it and they have to secure their own health care. But right now, Obamacare, since 2016, is paying for all this. That means you and I are paying for this.
Yeah, it's an abomination. Well, I could speak for a lot longer on that topic, but I do have our 8 rapid fire questions that I want to make sure I get to and respect your time. So, Dr. McCullough, if you could choose only one natural remedy for the rest of your life, what would it be?
Vitamin D.
Tell us something most people don't know about you.
I ran a marathon in every state in the United States.
If I were to compile a playlist of happy music, what song would you suggest be added?
U2, Beautiful Day.
Nice. What's your favorite guilty pleasure?
85% dark chocolate.
Nice. What is the most influential book you've ever read?
Border Trilogy, Cormac McCarthy.
What does the word revolution mean to you?
Change.
What does the word remedy mean to you?
Cure.
And if you could impart one piece of wisdom onto our listeners, what would that be?
Hold strong, use your common sense, verify everything, make sure you understand it and agree with it, and be bold and relentless in seeking the truth.
Absolutely. You can find Dr. McCullough on his website, on X, and on virtually every other news program that has ever existed. Dr. McCullough, where would you like to send people?
Well, start at my website, petermcculloughmd.com, after McCullough Protocol, the detoxification protocol. That'll take you everywhere. My podcast, America Out Loud Talk Radio, McCullough Report, every 2 p.m. Eastern, Saturday and Sunday at America Out Loud News. Courageous Discourse Substack. It's free to 90% of the content's free. That's where you get all the graphical abstracts, all the quotations, key videos. Then my book, Courage to Face COVID, couragetofacecovid.com. I'm doing everything I can, like you are, because we're in some type of crisis where things aren't going well for people, right, and they don't seem to be thinking straight. Thank you so much for having me. I'm Dr. Peter McCullough, Dallas, Texas.
Thank you, Dr. McCullough. Y'all take care.
With hope as a guiding light, through darkest days we'll fight the night. With a whole lot of passion, with a whole lot of truth.